What we have designed ultimately is a suite of interventions. An intervention essentially involves making a change somewhere within the system that's going to have an impact on the outcome that we want.
It needs to be targeted at groups who have the worst outcomes at the moment, who have the sort of highest rates of missingness.
Each part of it is kind of an essential part of the whole. Put together, they kind of mutually reinforce each other. It's about more than the kind of technical solutions that we tend to see, reminders, booking systems, and increasingly artificial intelligence and predictive systems. And it's about bringing back a kind of relational understanding that this is care that we're talking about. It's about bringing some of the psychology back into it and understanding that often people don't feel safe in the healthcare environment.
The really fundamental first thing we're wanting to do is to change people's opinions about what missingness means, and that's what we're calling applying a missingness lens, and there's a whole series of components to that. Understanding
What missingness looks like at a local level, whether it's for individual patients or within the kind of service system. Changing that perspective from a more kind of punitive and restrictive sense to something that's more supportive and positive and invitational, trying to bring people back into care, and ensuring that service systems are able to help staff to do that with the resources and the means and the support to make those kinds of changes.
Applying a missingness lens is a tangible way to achieve health equity in the NHS. You know, something that has been an ambition in the NHS across the UK for decades now. After that, what we need to get a lot better at, because we're terrible at it just now, is actually identifying patients at risk of missingness. That's not done at the moment.
That means identifying the individual patients who are missing or who are most at risk of missingness. What's happening for those patients individually and assessing their kind of needs. Taking those individual assessments and building a broader picture and a practice for the kinds of things that might be sustaining missingness more broadly. The third kind of fundamental element is missingness coordinator. In the stakeholder group we had missingness worker, and that is essentially somebody whose role it is to not only work with patients individually to address the causes of missingness in their lives, and that might be within the health service, but it might also be broader needs.
At macro level, it might be like that person's job is to look at an individual practice or a cluster of practices or a hospital and say, right, okay, what at the moment are the big drivers of missingness for the patients that come here, and what do we need to do as a service to change that? They're the sort of three big ticket ones, and then within that we've got the sort of whole focus on relationships.
Relationships and communication, and kinds of changes that are going to help build relationships of trust and often rebuild what are broken relationships for people with care, with the health service, with services more generally. That can be really instrumental things like ensuring people's communicative needs are met, and that can also mean training staff and providing staff support in trauma-informed practice, in patient-centred approaches, collaborative care, and I would say that is a kind of really fundamental cross-cutting theme. Every contact with the health service needs to be rooted in the principles of good communication. Contact around appointments means contact before an appointment that might have a reminding function, but might also be about helping somebody feel safe, reducing their anxiety, identifying and addressing some of the barriers they might have to access. But also it means making contact with people afterwards, taking that very welcoming, invitational approach so that people are inclined to come back again and inclined to start attending those appointments.
Another big factor is thinking about transport and logistics.
Our stakeholder group talked a lot about the different transport options that are available. That might be reimbursing bus tickets, providing bus passes or train passes. It
might even mean that they need somebody to accompany them to appointments, so that might be part of the role where the missingness coordinator would come in.
It might mean reducing the need to travel completely through home visits, telephone appointments, video appointments, practices and practitioners going out into the world, into other services to provide care, and actually taking those steps to get out to people rather than asking people to come in. Or if you are asking them to come in, making sure that their needs are addressed and doing it in a way that's very inclusive. The current system of primary care is quite rigid. It has very specific rules for access. And so when we talk about flexibilities, that might mean allowing people to drop in. It might mean providing people with a kind of open time at which they can come in rather than a specific appointment time. Prioritising them for more rapid appointments, giving them the means to make appointments in different ways. All those kinds of things that mean that things become more accessible and more flexible to their particular living circumstances. I think we have the tools and the knowledge and the information that's required to make a meaningful change in how healthcare is delivered.
Basically, GPs need funded to identify patients, have some level of missingness coordination in their practices, and then actually across the whole NHS there needs to be missingness coordinators and there needs to be core action taken.
I think we have a level of interest from people who have the power to make those kinds of changes. We have an opportunity at this particular point in time for those changes to actually happen.
It helps policy makers and practitioners, like there is actually a strong evidence base that underpins. So we're really keen to see the suite of interventions that we have pulled together actually turn into action in the real world. But that is quite a big ticket because we know how badly underfunded GP practices are generally at the moment, but specifically in the deep end. They are, proportionately underfunded, so the catch up is even greater. But I'm relatively optimistic that will change.